If you enjoy this content, please take a moment to rate and review it. Your feedback will greatly impact our ability to reach more people. Thank you.
Okay, welcome to Health Further. We have a guest host today. Marcus is out of town, enjoying himself. Rick Abramson, thanks for doing this. Really appreciate it.
Oh, man, thank you so much for having me, Vic. I am thrilled to be here. I cannot tell you how excited I am. This is great. What a great opportunity. Got to say, a little intimidating, sitting in the Marcus Whitney chair.
It is hard to step into the Marcus Whitney chair, but you have been a friend of ours, a friend of the pod, and then previously you've been on the show already. So this is old hat to you. We did, for new listeners, we did episode 73 about a year ago about AI in healthcare. And AI feels like changes every day. So a lot has changed since last July. So we'll dig into it.
For sure.
How's the week been? How you been following the news and getting ready?
There is like too much, man. I feel like buried by all the stuff
Yes.
going on,
Yeah.
It's been nuts.
Yeah.
But we're super happy to be here. I got to say, I'm a little disappointed. I was hoping that there'd be kind of in the Marcus Whitney chair, like a little setup like the Matrix, where I can plug something in the back of my head.
Yeah, and just immediately get all the knowledge.
Yeah, exactly.
And we don't have any fans. Eventually, we'll get a live studio.
I was hoping I'd walk out here like a jujitsu master or something.
Yes. So
next time, maybe.
Give the audience a little bit of your background. So you're a physician.
Yeah.
And then you left everyday practice and moved into the business side. But how would you describe it?
Yeah. Well, so. Man,
what kind of physician? Maybe you should give a little bit more of your background.
So former McKinsey consultant before I even went into medicine. Former Vanderbilt doc. I'm a radiologist. Former HCA for a couple of years. Former chief medical officer for a couple of AI startups. So a lot of formers in there. Hey man, I'm just healthcare curious. Like you guys. And man, there's so much interesting stuff going on. The intersection between the policy world, the tech world. And how it impacts on the whole venture ecosystem. Mm-hmm. It's a great time to be doing this stuff, man. And it's so interesting.
And then you left the U.S. regulatory area to pursue AI outside of the U.S. Talk about that decision and what it's like outside of the FDA kind of purview.
Yeah, well, so I was working with a startup based in Sydney, Australia. That did AI for medical imaging, and it's a lot easier outside the U.S. than it is here. It was actually, when I was there, it was really a tale of two businesses. You had the outside the U.S. business and the inside the U.S. business. And so now, new administration, maybe things change, maybe they don't. I'm sure we'll get into it. But regulatory is definitely a huge barrier for people doing AI, especially clinical AI, right? And we talked about that last time, clinical versus non-clinical AI. But a huge learning opportunity, and a lot of good stuff going on all over the globe.
Yeah, excellent. Okay, well, let's dig in. A lot of stories this week.
Let's do it.
Okay, we're going to start with the economy. You're a listener, so we start with the kind of economic backdrop for healthcare. And the non-farm payroll, the BLS, came out with their jobs report for April on Friday. And Marcus and I had talked about the preview. ADP had a preview that was disappointing, but the actual report came out very strong. 177,000 jobs ahead of expectations, which were 133.
Yep.
What's your sense of the payroll market?
Yeah. Well, first, thank you for starting here and reminding us that there are still traditional macroeconomic indicators that are important, right? I mean, it seems like the market is just moved by, the latest post to Truth Social, but jobs numbers are still important. And I mean, these came in, these were good. They beat expectations, but they didn't crush expectations. Yeah. They were not too hot, not too cold, dare I say Goldilocks numbers maybe. But the big asterisk there, right, is that these are probably a little too soon to reflect any changes in hiring from the tariff announcements.
Right.
So
Yeah. And so then we had the Fed meeting yesterday, well, Tuesday and Wednesday, but Jerome Powell came out yesterday and gave his discussion. And he kind of had a similar reaction to yours. He's in a wait and see. He's not going to be preemptive and think he can guess where the economy is going, but more kind of ready, watching pricing, inflation, watching the jobs.
Yeah.
Right now, he is sort of following the data and watching things come in. What are your thoughts about that? Is that where you think you should be, or what are your thoughts about that?
Yeah, well, it's said so often now, it's become cliche, but I'll just say it again. I wouldn't want to be Jerome Powell, I mean,
right.
like you can't lower rates because of inflation. You can't raise rates because, GDP numbers are starting to get a little soft. One day he's getting fired, the next day he's not. I mean, what's the Fed chair to do, right? So here he's kind of kicking the can down the road, which is very, I think, appropriate because we don't know. Like the impact of trade negotiations would be huge. So it's wait and see, I think, for the Fed.
Yeah, that's certainly where he is. I have been, and I still think, because policy takes 3, 6, maybe 9 months to really take effect, I think that the tariffs are going to have much more of a drag on the economy than they'll have an inflationary effect. So I would have liked to see him take a small step into accommodating, but I'm a VC too, so maybe, well, of course.
Yeah, and maybe short-term inflation followed by long-term drag.
Yeah. No question, short-term inflation. But
then it's hard to hit the timing right.
Yes. Yeah. Right. Okay, moving on to the next story. So Trump and the U.S. signed their first trade deal with the U.K. today. And so good to see some progress. What were your thoughts about this first deal?
Yeah, I mean, markets seem to like it. I think they're looking for any kind of good news. I haven't seen the details of the trade deal. I don't know how much changed. And that's what I'm going to be looking to see.
Yeah, I think that's because there weren't many details. Yeah. There was sort of combinations for UK steel and automotive. But I think it's positive that we got a deal signed. I don't think it's that surprising that the UK and US can strike a deal.
Yeah.
We had a trade surplus with the UK last year. So this is not like the most important one, but it's good to get some momentum maybe and get the first one done.
Right. And if your metric is the trade deficit, then this is an easy one for you.
Right. Yeah. U.S. and China officials are meeting really for the first time to have trade talks in Switzerland, kind of a neutral party.
Yep.
I don't think it's high level. Trump and Xi are not going to be there. But what are your thoughts about this?
Well, from what I understand, the way this happened was that, U.S. and China just not talking to each other at all, refusing to engage. And then maybe like a week or two ago, China sent some kind of like signal, kind of basically saying like, it was about fentanyl, right? And it was kind of like, do you think I could do, what do you think I could do about fentanyl?
Yeah.
And U.S. is like, I got some suggestions for you. And that kind of opened up the pathway to this, to everyone talking, to them talking. So, it's good news, but they've got a long way to go.
Yeah. I mean, unlike the UK, which was relatively easy, with a lot of work to do with China, but positive that they have started or they're about to start.
Right, and a lot of pressure on both sides to engage in these talks.
Yeah, that's right. Okay, moving into the venture sort of roll up. So, TSOLife raised $43 million in a Series B, led by Peakspan Capital. So they produce a product that helps senior living, assisted living, bring better experiences for their residents. What do you think about this deal?
All right, so I got to tell you, I looked at this and my first thought was that, remember that Saturday Night Live sketch a couple of years ago? It was the Amazon for seniors, like the Amazon Alexa device for seniors. Hilarious. You got like Kenan Thompson can't pronounce Alexa. He keeps going, Clarissa, Odessa. And you got like the Kate McKinnon character who's like telling it to turn up the heat in the room. So this is not AI for seniors, but it's AI for operators of senior living facilities. Right. And so from what I understand, you do an interview with the nursing home resident or the senior living resident coming in. And then based on that interview, it's going to generate some insights to help personalize the experience for the resident, like suggesting customized activities and, friends that they can make. The example I saw was like somebody comes up to a facility director, they want a bridge partner, and the dashboard will suggest a bridge partner.
Yeah, Vic also likes bridge.
Yes, exactly. That's right. I don't know. I mean, sounds nice. I don't know if not really a must-have, or maybe I'm being too harsh. I don't know.
I think I agree. I mean, I'm hopeful. I think our seniors deserve to have better experiences. So that sounds great. It's a good vision.
Yeah.
And at the same time, for the past 20 years, I have invested in and lost money in various technologies to make the senior resident experience better. And just adoption is hard. It's not, there's not a lot of motivation to bring new things like this in. But I'd love to see it get adoption.
Yeah, for sure.
Next one is FoodHealth Company, raised $7.5 million in a Series A as they pivoted their business model. So this was a food as medicine startup in San Francisco, maybe 5 years ago or so, when food as medicine started being really hot, and your insurance company would subsidize healthy food for you. And now they're pivoting.
BiteWell before, right?
Yes, BiteWell. Guess a little bit, not quite that long ago. 2023 is when they raised their seed round.
Yeah.
And they're now pivoting because food as medicine and subsidizing food for members is kind of out of favor or not as common anymore.
Right,
Medicaid maybe won't subsidize that for very much longer. So they're moving more to work with grocery stores about advising people on what is healthy and what's not healthy.
Yeah, I saw that they're they have a deal with Kroger. So across that portfolio that includes like Harris Teeter and Ralph's. And I haven't been to Kroger in a while. I want to go in and see if I can look for this. So this is it basically gives you a score, right? Like a score, a rating from 1 to 100 on the food and its nutrient density and the ingredient quality. And pretty interesting. I think really, I mean, I think the most important thing here is how it fits into this whole food is medicine, make America healthy again, kind of movement, which I think we'll talk about in a little bit. But I mean, this is kind of poster child for that type of stuff.
Yeah, and the chief medical officer at Kroger is a friend of mine from he's from Nashville, Mark Watkins. Okay. We were in fellows together. Yeah. He's been trying to bring food as medicine sort of concepts into the forefront at Kroger for a long time. Yeah. And so hopefully this will help there. Okay, then last one in the venture, Deerfield Management, one of the strongest, largest VC firms in healthcare, raised a $600 million fund, which is smaller than they have raised in the past, and they called it a constrained market. So good to see them get their fund closed. But if Deerfield is having trouble, the entire market's having trouble.
Yeah, kind of a mixed message a little bit, right? I mean, it shows that you can still raise, but it took them a long time. I think it took them 18 months to complete the raise. And so, people are still investing, but there's a lot of hesitancy out there. Yeah, and we haven't had a big biotech IPO in a while, right?
Right. Yeah, exits in general across healthcare have been sparse, let's say. Yeah. Okay, moving into the policy. This is where I think you really have a lot of depth. And so the first story in the Wall Street Journal, Trump picks a MAHA moment leader for Surgeon General, Casey Means, who I've read her book, Good Energy, and she's pretty widely known for her discussions around food and kind of getting the right kind of food. Is going to be the Surgeon General, which is controversial. She is a doctor, but she hasn't practiced in a while.
That's right.
So I don't know, what do you think?
She's nominated for Surgeon General.
Yes, sorry.
So she has not been approved. And the controversy, there's a lot of controversy around her, which we could go into. But, I think you paired this article with another article about.
So maybe let's chuck both at once. So the next nomination, is it Vinay Prasad?
Vinay Prasad, yeah.
Yeah, so he is nominated to succeed Marks at CBER, which is the research Center for Biologics Evaluation and Research, part of the FDA.
Yeah, exactly. So I think these belong together because to me, these are really important because what we have is Health and Human Services now starting to fill out their kind of second.
Right, where a lot of the actual work gets done.
Exactly.
The heads of it then nominate these lieutenants that do a lot of the day-to-day work.
Yeah, so we have heads for FDA, N.I.H, CDC, CMS.
Right.
But now these are the deputies who kind of like really kind of do a lot of the work. And, these appointments, I think, reflect a lot of where the administration is going in terms of policy priorities, which then, of course, translate into research funding priorities and device approval pathways.
Where does the Surgeon General sit in the HHS?
Surgeon General, I believe, reports directly to the HHS secretary. I'd have to check the org chart, but that's kind of technically the Surgeon General is over the public health service, right? So these are, I think it's like 8,500, public health, public health servants basically that report up to him or her. I don't know what the final number is going to be with
right,
but that's, I'm pretty sure that's right. They're not within CMS or N.I.H. or FDA.
Okay,
I do know that. Now these two, Casey Means and Vinay Prasad, right? These are important because and I don't want to put them too much together because they're individuals with their own agendas and policies and everything. But like, so not to paint them with too broad a brushstroke, but like they're both kind of in the vanguard of this MAHA movement, right? This Make America Healthy movement.
Which I think really almost starting with Trump, but Trump and Kennedy, and then all of the appointments, I don't think there's an exception. So to fit with this direction. Yeah. And it's a pretty different direction for HHS, which is not find ways to care for our sick population.
That's right.
But instead, how can we make Americans healthy? How can we keep them from getting sick with exercise, going outside, food, things like that, which if successful would be wonderful.
Yeah, for sure. It's
the question is like, can we get there, or how do we get there?
Yeah. And people like, a lot of people ask, like, what is this MAHA thing? And it's hard to really capture because there's so many different strains it's pulling from. But I think you're hitting the nail on the head. I mean, I think at the core, it's about this idea that we have neglected chronic disease, or that we have not prioritized chronic disease, and that we need to look at more prevention, rather than downstream treatment. And so, this movement is talking about, better food choices and cleaner water and getting more exercise and getting more sleep. And at the same time, there's this kind of other strain that's kind of like looking at the downstream treatments and saying, like, maybe we do too much, maybe we push too many pills, recommend too many procedures, and maybe there's not good enough evidence for a lot of the stuff that we do. And I think the final strain that you kind of hear this coming out in some of the policy discussions now is that this idea that that the way we got here is somehow related to the influence of big food and big pharma and big biotech, right, and their relationship to government, and that maybe that relationship's been too cozy, and we need to kind of blow that up, get a little more distance between industry and regulators. And you already see that in kind of policy proposals coming out. Yeah.
So you have spent a lot of time thinking about policy, particularly in radiology, but across medicine. And I want your thoughts on a framework that I'm not totally able to articulate, but I'm going to try and try to bat it around just for a minute with you, which is, I think there are kind of three different aspects of health broadly. And they're kind of reflected in HHS, where there's public health. And that was probably the first place in a historical lens that humans really started working. Infectious disease, clean water. Let's just try to understand how we can take care of our population. The next was then acute medical treatments. So you get hurt on the manufacturing line or on the farm, and we need to patch you up and send you home again. So that acute intervention, surgery, and the doctor is kind of acting on the patient. And then there are medicines as well, but they're short term in nature. It's an acute event, and then hopefully you recover from it and you're no longer under care. And then there's chronic disease and the treatments related to chronic disease. And I want your thoughts on the idea that it's almost like a hierarchy. You can't address the acute disease or chronic disease if you have hard public health and you have cholera and you have, disease, really difficult to focus on anything. And then acute is kind of the next, that you get in a car accident or you have a broken leg. And it's actually a sign of success. Like, our system has been successful at treating these first kind of two major rungs of overall health, that now we get to address chronic disease. When people died at 50, 200 years ago, there wasn't a lot of chronic disease, but it's better that they're living much longer. And part of the effect of that, though, is that we have chronic disease. So is that a useful way to think about things? Or what are your thoughts about
like
that framework?
I like that a lot. It's very similar to a framework that I always kind of come back to, which is genetics, environment, and behavior. Just kind of like a triangle. And like, I mean, we know that there's a contribution for most disease.
Yeah, most of them
all those three.
Those three are contributing.
Yeah, exactly. And there's a question, and it's just how much is weighted, and how much, what's the most important one. But we have branches of government, branches of policy that deal with all three. And I think right now we're seeing, we put a lot of emphasis into genetics research over the past several years. And you'll hear comments about, like, you walk around the N.I.H, you can't take a step without bumping into 12 geneticists. And I think that's actually been really helpful, and that's given us a lot of amazing interventions that we can actually use for patient care.
But that's not everything.
It's not everything, And so now, maybe we're going to shift the focus a little bit, maybe towards behavior, and then the environment obviously is the last piece. And environment's interesting because that's kind of that's out of certainly the purview of FDA or CDC, N.I.H. I mean, you're talking about EPA, you're talking about clean water, and already we're seeing some I wouldn't say tensions, but maybe some kind of like push and pull within the administration, kind of like rolling back some environmental policies, environmental regulation. I think we're going to see kind of there's a lot of interesting kind of axes of potential tension right now, because you're pulling together people from so many different paradigms and different themes.
Which is probably good. I mean, if we can make the EPA work in a constructive way with HHS, that would be positive.
Absolutely. Yeah, for sure.
Part of the reason I wanted to frame this sort of multi-step process of bringing health to a population is I don't know that big pharma or big food or big anything are bad people. I think, sort of pharma has delivered incredible medicines that have really helped both in public health, in sort of infectious disease, and then in acute care and in chronic care. But the business model, or how we incentivize them, maybe needs to be rethought for chronic disease, where you might be taking this medicine for the rest of your life. That's a different thing than taking it sort of post a surgical procedure for 15 days or 30 days.
Yeah, I think that's right. And I think one of the criticisms of the MAHA movement is that maybe it's too much downplaying the importance of these drugs and procedures that we do use, that we do have good scientific evidence for. And now we're going to shift the focus all the way up to prevention and maybe kind of leave some of this stuff, kind of neglected. And that's the debate that's going on right now, right? This one of the this Vinay Prasad is an interesting
I don't know him. Dr. Means, I've read her book, but what's his background?
He has made a big name for himself as kind of a contrarian. I use the term contrarian, kind of like, I got to be careful because like now what was contrarian is now mainstream.
Now leading the country,
like,
and they're in a position of power.
Well, yeah. But he's a very well trained hematologist oncologist. He practiced out of the University of California, San Francisco. Very well trained, very kind of like respected, but has made a name for himself as a skeptic of a lot of the cancer screening procedures that we have, like colonoscopy, mammography. He has a background in epidemiology, trained at the NCI, spent a lot of time there. And so his basic message is that we need better evidence for a lot of stuff, and we need to hold things to higher scrutiny. Which, again, talking about these kind of potential axes of tension, right, within the policy world now, we've got FDA leadership has come out and said, we're going to streamline drug approvals. We're going to get innovative treatments out into market. We'll have accelerated approvals. We will we'll make sure that promising therapies are delivered to patients as quickly as possible. On the other hand, you have another kind of counterweight, basically saying like, hey, slow down. We're going to actually, take a step back, increase the level of scrutiny, make sure that we have the required evidence, maybe require more from developers and manufacturers before we approve stuff. And so the biotech, S&P biotech index, I think that was So the reason why stocks fell so much is because his being brought in, I think, is seen as shifting the balance a little bit more toward that higher scrutiny, higher evidence threshold and potentially longer approval times.
Yeah, and I have seen, I can't quote it, you might be able to, there are studies where cancer screening with all the false positives and then the ongoing further tests and looking into things can be, in a population view, negative, where you have more of a negative effect than the positive of catching cancer early. So that balance of actually running the studies and looking at what is best to bring to market or to allow in the market, I think probably is a healthy thing to think through for the FDA. What are your thoughts about that?
I think so, and it goes into, I mean, there's a lot of startups in the wellness and longevity space that I think, all these questions kind of float around them. I think we've talked about Prenuvo and Ezra and some of these kind of full body scans, which deal with the exact issues that, people are raising, false positives, false negatives, false sense of assurance. But, we want to empower consumers, let them decide, let free markets reign. But I think at the point you hit is really important. You get into this kind of paradoxical situation where what you recommend for a population is not necessarily what you recommend for an individual. I have a lot of problems with the idea of like a Prenuvo scan for everybody. That to me raises a lot of questions. But I got to say, I've had a Prenuvo scan. I found it pretty helpful. I got some good information from it. So, and on an individual by individual level, that you may actually like recommend something.
And that's an interesting way to dig into HHS broadly. FDA has a function of safe and effective. Is that right? But then CMS is more like, what should we pay for out of Medicare? And Medicaid, and those things for a long time were very married together. Like once something got approved from the FDA, it was very quickly approved for reimbursement.
Right.
And so that's been separating. And that's probably how it should be, right? Like this full body scan is safe and effective at telling you a lot of information. Whether that is good for CMS to fund for every Medicare recipient, I don't know that would be good for the recipients themselves.
Or the VA for every veteran.
Right. But then you get to this class distinction where then people can pay for it themselves and they get access, which is difficult.
It's problematic. Yeah, absolutely. Yeah, and that's what we're all wrestling with.
Yeah. So some of these people, or you're 1 or 2 degrees separated from them. How do you think it's going to shape up with the next 6 months, 12 months, 2 years?
All right. Well, so we talked a little about kind of like what defines the MAHA movement. I think in all fairness, we probably should talk a little bit about the pushback, the criticism of it. So we talked about kind of moving the emphasis to kind of upstream to prevention, right? And we talked about clean food and water and exercise and sleep. A lot of these MAHA influencers are pushing kind of things beyond that, and they're talking about supplements, and they're talking about infusions, and they're talking about wearing a bunch of devices, and that's raised some eyebrows because the evidence for those things aren't that great either, right? Like the exact same, they're accusing the mainstream legacy media medical establishment. This is kind of the same apply here. And then there's some conflicts of interest issues that have been raised, and some of these guys like kind of getting paid to promote certain products or having a financial interest in companies that they if it is right to not have pharmaceutical interests on the committees that are approving drugs, it's also, you can't have a supplement interest, or you can't have a device that company you own 10% of is marketing. That seems pretty straightforward. Is there that conflict, that kind of conflict going on, where it's
they're pointing fingers at other people, but then they're doing the same thing on their side.
Yeah, I mean, I think
that's the criticism.
That's the criticism, right? That there's, they have a financial interest in companies that they're talking about, or they're have consultant agreements, or they're getting paid to promote certain items. I mean, Vinay's picture's up here. I'm not saying that Vinay is
right.
In general, that has been a criticism of kind of some of these wellness influencers, let's call them.
One of the things that I don't know enough details to give an example in that thing, but last night with my son, who's 18, we were talking about Trump's crypto coin.
Yeah.
And my position is he was very transparent about that. And I mean, it's I forget what it is, but it's like the Trump coin. It's not behind the scenes. And I think if someone wants to purchase what is a lottery ticket of the Trump coin because you think it's going to go up, it's gambling, but I don't see that as bad. Maybe he's using the White House in a way that is not what I think is the best thing to use it for, but it's very transparent. And so to me, the transparency in the FDA and HHS is the thing. Like, either you are allowed to be on these committees that approve things, and you have to disclose what you have, or you're not. But a lot of times the disclosures in the past 40 years have been not widely disseminated, right? It's disclosed somewhere on a website, but it's not very clear, and everyone in the committee has various conflicts. What are your thoughts about that sort of line of thinking?
Yeah, I mean, I guess with the analogy to Trump coin, I mean, I'd say that blind speculation is probably okay. If you don't have any insider information, you're just like, I'm putting a fiver down on Trump coin, and it's going to pop tomorrow. That's fine. But paying for influence, I think that's where you kind of start crossing the line, right? And so
like, hey, Rick, Trump, this is not true. Tell me when he's going to announce something, and then I'm going to buy it in front of that. That's inside information in the purest sense of it.
Right, exactly. So if you have a line into what's going to happen with a certain regulatory decision, or if you can influence that regulatory decision, and you happen to have a financial interest in the decision, I think that crosses the line. And so in the whole disclosure thing is interesting because, like, disclosing your involvement with an entity, in certain circumstances that might be enough, but in others that might not be potentially. Just because I publish a paper and like in fine print at the very, very bottom in like 8-point font, I say like, sponsored by a grant from Pfizer or something. May not necessarily be enough if that's a market moving paper that was clearly influenced by by my funding source. I think it's case by case basis, but I do agree that this stuff needs to be out in the open. I think transparency is important. And it's stuff we should just be aware of.
Okay, good.
But anyway, so like just wrapping up here, I mean, like you asked kind of like my thoughts on just kind of like the whole movement and its effect on the ecosystem. I mean, I would say that if I'm an entrepreneur and if I'm in that, preventive health or wellness or food as medicine or functional medicine, whatever you call it, I think you're getting some tailwinds here.
And what about AI at the FDA? I mean, you had to leave the U.S. It's pretty unclear to me where that's headed right now.
I think too early to say. They just announced an AI czar coming from the private sector. I don't think it's a physician. I think it's someone coming from the private sector business world. Don't know much about him. But this is where this tension between kind of safety on one hand, guaranteeing safety and promoting innovation, that is really going to come to the forefront. So I would love to see some of these more innovative software products get out to market quicker, maybe lowering the evidentiary burden on developers so they don't have to have like a $10 million clinical trial in order to get like a piece of software to market. But I think on the tail end, that probably means raising the post-market surveillance requirements and gathering data after a product is out in market already. I think overall, it's a matter of making sure that the benefit and risk are in line with the the evidentiary threshold that we're putting in. So if something's super dangerous, you want to require a lot of data. If it's a tongue depressor, maybe
go ahead and do it. Yeah. Right. Okay, great. Justice Department brought a lawsuit to Medicare insurers that they are improperly funding the brokers. They called it alleging kickbacks, where they are paying the brokers to steer customers that are more profitable to their plans.
Yeah.
What do you think of this story?
There's policy backdrop here as well, right? So Mehmet Oz, I think, has been very supportive of MA for a long time. He's a big fan, but he also said in his confirmation hearings that he was really going to go after these kind of questionable payments, right, going to Medicare Advantage plans. It sounds pretty bad, right? Like paying kickbacks to brokers to steer patients into higher cost plans, and not only that, but they're paying, or at least alleged to be paying brokers to keep the sicker patients out of the plans,
right?
Because they're more costly. That's not great,
right? Exactly. So if they can substantiate this, and the accusation is not, they have to go through the whole process. But a lot of the things in this article looked pretty circumstantially negative.
Yeah, exactly. And this is one of these things, like Medicare Advantage is pretty popular, right? It's more than 50% of enrollees now. But it keeps getting more and more controversial among policymakers. And it's just because there's so much opportunity to game the system, right? So there's a lot of startups out there that are built around risk adjustment, right, and helping these plans risk adjust, and you kind of think they're going to be facing higher compliance headwinds going forward. I would think. I don't know. I think
definitely. I think they should. I think they should be.
Yeah, for sure.
Okay, so we've been talking the last month or maybe even 2 months about supplemental payments, and so the New York Times called it the Medicaid loophole used by 49 states to grab federal money. We've talked about it almost every week on this show because Congress is looking to find savings, and there's a ton of money. I think it's $800 billion or so every year into this particular, as the Times said, loophole. And what I liked about it is this article, they go through the whole, summary of it, but they have a really good chart here of how it works. Supplemental payments are super confusing. The Times did a really good job describing it. So the way that it works is, the state government will make a payment to a hospital. This is the traditional way. And if they pay $1,000 in this diagram, the federal government will reimburse 60% of that, or in this example, $600. And the loophole or the game that some 49 states have started doing is they charge a tax to the hospital, or usually an association of hospitals, and collect tax money, and then they use that tax money to increase their payments. So say they get a $30 tax in this example, they then pay all of that back to the hospital. So the hospital has paid a tax but gotten it back 100 cents on the dollar. But then the state gets a higher reimbursement because 60% of that higher number is, of course, more money. And they do that over and over and over again, $870 billion annually. I was a little bit off on the amount. So what are your thoughts about this whole?
It's super clever, right? I mean, it's just kind of genius.
Yes.
And
it's hard to stop. I mean, it's difficult to stop while also having Medicaid payments exist.
Exactly. Well, like one person's loophole is another person's way of making sure they can meet their Medicaid budget, right? So this is a tough one. I was surprised by the magnitude of the potential savings here, right? So, I mean, right now on the Hill, House Ways and Means Committee is trying to find a way to save $880 billion.
Yeah, and this is
Medicaid,
870.
and this is, so I think that was total. They were sending Medicaid, I think it was $600 billion over 10 years. So it gets you pretty far, pretty close to that number. And, that would be pretty nice if like the Congress could just like snap their fingers and have $600 billion.
Yeah, it would be
here, right?
It's interesting. It would be nice at the federal level, but then, so now we're showing the states that are most responsible for that amount of money.
Yeah.
And Tennessee, where we're sitting right now, is one of the, it's like a bright orange 30% share of Medicaid funding through taxes. So, but it's like we said, it's 49 states. It's almost every state. It's if the federal government saved that money, it would inherently then be incumbent on the states to figure out a way to pay for that. Or cut programming.
Exactly. Which is, I think, why this has, they have been trying apparently to close this loophole, if you want to call it that, since the late 80s, right? And they haven't succeeded. And this is why. The states really depend on this mechanism to meet their budget. And the other thing that jumps out about this chart is that it's really disproportionately the red states that are affected by this. So G.O.P. lawmakers are not going to be jumping to do this anytime soon, I think. But it is pretty interesting to think about the magnitude of savings there. The problem the House faces right now, or Congress in general, is that, as you guys have talked about this, 880 billion, that's a big chunk of change, and everybody wants to wave their hands and say like, oh, we're going to cut down on fraud and abuse, and that savings is going to appear. But that's that's not going to happen. It's not even to an order of magnitude, close. And so, they're facing a pretty tough set of options up there, right? It's like lower the federal matching rate for Medicaid, lower the federal, the federal subsidy match for ACA, beneficiaries, do work requirements. Block grants. All these things.
Whatever you pick,
nobody wants to do anything.
Someone's not going to like.
That's right. Exactly. So it'd be nice if this could just materialize and have no impact on the state budget, but that's not going to happen either.
Right. Moving on, Healthcare Dive had a story about Trump ordering the FDA to help speed the building of new drug factories, which I think is great. I don't know what so the idea was that the FDA should reduce regulations so that factories can be built more quickly. What are your thoughts about this?
Yeah, I'm not so down in the weeds on this one. I don't know exactly what regulations would be rolled back. It just this makes sense. I think. It would make sense that this would be happening, right? It's like we're going to onshore pharma development. We're going to kind of be more resilient in terms of supply chains. We're going to maybe create jobs. Although we were talking about this before the podcast. How quickly can you really spin up those jobs, right?
Yeah. Well, part of reducing the regulation, I think, is to try to answer that. Where I think the capital is probably ready to go, but when you actually go to try to break ground and stand up the building, it's complex with local, state, and federal regulations.
That's right.
So now N.I.H. is going to ban new funding from U.S. scientists to partners abroad. So I didn't know about this before this story in the New York Times, but I guess there is a possibility for the N.I.H. funds a researcher in a U.S. academic medical center or research facility. They can then sub out pieces of that to international labs, or they used to before this executive order.
Yeah. So this is what we're going to call it research nationalism, maybe?
Yeah, I guess so. We are pulling in all the research to only be done in the U.S., which I guess is okay, but maybe there are... I'm torn about this. Maybe there are things that can be researched in other countries that wouldn't be allowed here, but are we exporting then things that we wouldn't want to happen in our country?
Yeah. It probably depends on what we're looking at, but this is, it's, I think at the foundation is driven by security concerns, right? So security concerns with China, and also kind of an effort to bring.
The gain of research is the most obvious one that was outsourced.
Exactly.
Caused trouble. Obviously,
that did not work out well.
Right.
Yeah. So this could potentially help. Some U.S.-based CROs and maybe some U.S.-based labs. It's not great for global scientific collaboration, especially coming after withdrawal from the WHO and some pullback from some other things. But
probably negative for biotech, I think.
Right. Well, especially if you have if you're dependent on a research agreement and you're kind of doing research in India or Israel or China. It's probably not great because it's more expensive to do research here, which is I think the point. Right?
Yeah. Right.
So we need to attack those costs.
Right.
And, and maybe that'll kind of spur more domestic research activity.
Right. On the other side of that, U.S. Is kind of curbing or pulling back the AI chip export bans. So the industry, NVIDIA basically, and the rest of the industry has been lobbying to stop this limitation on their ability to sell to China and other places the best chips. I understand why that they don't want those limitations, but I think it is important to limit China's ability to continue to build out AI towards artificial general intelligence over the next year or two. What are your thoughts about sort of this really change? The Trump administration was strong on it, and now they're changing, sort of coming back to it.
Yeah, well, you just have to take one look at NVIDIA stock performance after this announcement to know, right? I mean, I think it went up by over 3% on this news.
Right.
And I mean, look, that chip industry doesn't like caps on exports. But, this doesn't mean that there won't be caps. There will just be a different form of export caps. And so,
but it's going to delay the caps for a while. Yeah. Meanwhile, NVIDIA's sending chips all over the place right now.
Exactly.
So that is the policy. So moving on to the payer side, we just have two payer stories. CVS beat expectations, which was good to see. But more interesting, they are withdrawing from the ACA exchanges where they claimed they were losing money. So they will no longer participate in the ACA exchanges. And then they also struck a deal with Novo Nordisk to sell Wegovy at reduced prices in their stores. So very similar to last week, Novo did a deal with Hims and Hers. They're definitely building up distribution partners in the U.S. What do you think about CVS?
$499 a month, according to the article, out of pocket. So go get your Wegovy. I guess
that's right.
So this is interesting, I think, on a couple levels. I mean, it shows how competitive and costly that ACA space has become, and it's probably CVS Health. I mean, they've been kind of toying with this for a long time, right? And kind of so they're finally pulling out of the marketplaces, and they're probably just kind of doubling down on what they do best, right? Which is retail and pharmacy. And the announcement with Novo Nordisk, that's great. That's great for them. And it's great for Novo Nordisk, because they're, like you guys talked about this last week, they're kind of battling the
they're trying to catch Lilly's.
Exactly. So it's good. This may open the ACA marketplace a little bit to some smaller players coming in. But it also
hopefully. I think it's I hope so. I think there's not enough payers in the marketplaces. But
and in the short term, you're raising kind of some coverage access concerns, right? Yeah.
Okay, then Clover Health, which has been really struggling for years with Medicare Advantage, small kind of tech-forward startup, Clover Health. They had a successful quarter. They beat earnings and are growing pretty well. So they seem like they're back on the growth trajectory. They've taken a significant. They were a high-flying, super exciting stock post-pandemic, but not anymore. Yeah. But now they're coming back. Maybe
these guys have been around for 10 years. I didn't realize that. I thought they were just little babies. But they look like they're turning around. They had struggled for a long time.
That's right.
And so now they're cutting costs. They're raising their revenues. Maybe VC fueled payer models are not dead.
Maybe. I don't know. I think it's a long way. I mean, they are back to growth, but they've come down quite a bit. So at some level, when you get the base effects low enough, then eventually you're going to start turning up. Yeah. Okay, switching over to the health system. So here locally, Vanderbilt Medical Center, we sort of knew this was coming. They got hit from the N.I.H. Reduction in grants and overhead, and they have done a hiring freeze, and then also they're making layoffs. They didn't announce in this news channel, local news channel 5 story, how many layoffs. I think it's going to be pretty significant. We both have friends over there. I've been hearing it's a decent number of people. So sad to see, but not surprising.
I know. I hate to see it. It's tragic because when you're here locally, and you see it happening. I mean, you really realize the personal impact, of these announcements.
And if you're a PhD research biologist at Vanderbilt, it's not like you can go to another academic medical center. They're all have hiring freezes or cutting back.
Sure.
So it's countrywide. So I'm fearful that I'm not sure where these people are going to go next.
Well, there was another article too. I don't think it's in our packet, but it was an article about how countries abroad are now kind of like shimmying up their packages to try to attract U.S. researchers. So
I mean, I think
maybe they go abroad.
Yeah.
You know?
Maybe they will.
But these are not just researchers; these are kind of frontline employees, staff at all levels. And I think like kind of stepping back from the personal, kind of like how immediate it is. I mean, I think what happens at a lot of these academic medical centers is they do have a tendency to get a little bit fat. I mean, just kind of just the way they operate. And I think every once in a while, there's like every 5 or 10 years, there's a big shock to the system, and that's when the AMC kind of takes the opportunity to kind of trim back. And so maybe these are...
So in the long term, it could be okay, could be healthy.
Yeah, I think so. Yeah, kind of pruning the tree, but it's hard to explain to when you're one of the leaves.
Right. Yeah. Right. Yeah. Oregon Health and Science University had a merger they were trying to put together with Legacy Health, which also is out in Oregon, and that fell apart. So it was going to create a pretty big system with over 100 locations, and it's not clear what happened. But the deal, I don't think it was stopped by regulation. I think either the two sides couldn't get to a final agreement or something changed, but the deal fell apart. What do you think about this?
So it could have been regulatory. It could have been, I think there was some local pushback.
Yeah,
maybe there was a culture clash.
I think some of the I think they're union based in Oregon. So some of the nurse unions and things were sort of asking for in their contract negotiations, and they hadn't had that figured out. So there were aspects like that could have caused it to go away.
And there was some local regulatory body that was trying to put the kibosh on it as well. I guess the question is this a one-off, or is this have implications for regional consolidation all over the country? I don't know. What do you think?
I think it is. When we just talked about the Vanderbilt story, I think academic medical center, so Oregon Health and Science University is not as big as Vanderbilt, but they're in the same category as Vanderbilt.
Yeah.
And I think there's just a lot of uncertainty about, I mean, maybe it is every 10 years they go through this transition, but when you're going through that and you have a merger process in play, I think that was the question mark that was uncertain. Yeah. But I don't have evidence of that. It's just my thought. So academic medical centers, I think, are under stress right now, and
a lot of them grew pretty rapidly and took on a lot of acquired community hospitals, trying to build out their referral networks, and who knows, maybe Legacy took a look at the financials and saw stuff they didn't like. But that's total speculation. No idea if that's what happened.
Okay, this was an interesting and hard story in fierce healthcare. It really is a news story covering the McKinsey report, which we will add the McKinsey report to the show notes as well. But the title is Helping Nurse Managers Tend to Their Frontline Workers Cuts Down Turnover, which seems, fairly straightforward. But there was a lot of really interesting and difficult kind of updates from how the nurse workers in our healthcare system are doing broadly. And I was disappointed because I thought we were doing better. I mean, this was, sort of top of mind in the pandemic and right after. And it seemed like we were getting a little bit better, but
hasn't really gone away.
But it hasn't really gone away. So we're just looking at the McKinsey report now, and like all McKinsey reports, they had a couple of graphics in here. So
of course, you have to have that.
Right.
McKinsey report. Yeah.
And so this chart is sort of maybe 10 or 12 of the reasons that their nurses are not factors that contribute to nurses' decisions to leave a position or how they're not feeling valued. And the number one is that they're looking for another better job, but that's not that useful. But then they don't feel valued by leadership and they don't feel valued by the organization are 2 and 3. And then it goes to compensation and advancement. I don't know. What are your thoughts about the nurse community.
Yeah, so the report is a really interesting report, like you said, and it's kind of suggesting that a big lever for attacking this kind of nurse attrition problem is through nurse managers, right? And give them managers more resources, more training, more support, more mentoring. And the list is a bunch of things you can do, like reduce administrative burden and reduce stress. And I mean, yes to all the above, right? I mean, like I'm certainly not going to argue against de-stressing, managers. I got to tell you though, I also think that I personally think that we really need to kind of totally rethink the whole nurse and nurse manager model. I mean, because what happens right now is you got the best frontline clinical workers, the ones who are just really, really good at delivering nursing care, and they're the ones who are elevated up into the nurse manager position, and potentially maybe their skills aren't that great for a managerial role, right? And
it may not be as rewarding too.
Yeah, exactly. And they're taken out of clinical care. And so, clinical care, that potentially suffers. The morale of the other nurses potentially suffers, I don't know the solution.
It's interesting. So one of my portfolio companies, which of course I'm completely biased for, called Gracia Health, they've had a really interesting thing so they're in nurse engagement and nurse retention. That's their line of business. And they found that if they could get a nurse to become a preceptor, and they created an entire training system, not only did that help with onboarding new nurses, and which of course we need more preceptors to sort of help with that last part of the training process. But that was not surprising, but more interesting is that nurse then, they didn't move into management, but they felt much more rewarded, and they retained the one that learned to be a preceptor. I think it is more like you're building community in the nurse population, and they kind of know each other. And I don't exactly know why, but it was interesting that if you become a preceptor, you're more likely to retain.
Yeah. And there's also there's just market forces too, right? I mean, I think you get paid a lot more as a travel nurse or a locums nurse than as a permanent nurse. And so, all the nurses want to go into locums work. And so in the healthcare facilities are doing more locums hiring. And it's like this kind of like negative or positive feedback cycle, depending on who you are. And that's not really, doesn't get addressed by the managers.
Right. Virtual MSK provider Include Health rebranded as Lanya. How do you say it? Lanya Health? Lena, maybe?
Lena?
And so this is a virtual physical therapy company, and they are sort of rebranding and focused on really bringing that to market. I think it's related to the next story, so let's talk about that too, which is Hinge Health, which filed an S1 to go public. They've delayed it, which is not great for them, but it's good for us that we now are getting their financials, even though they're not public yet. And they are doing really well in the same space, in that sort of virtual physical therapy rehab space. And so I think these two sort of stories fit together a little bit.
Yeah, it really makes sense, I think, for Include Health to pivot over and follow Hinge, because Hinge is doing so well, right? It looks like Include Health used to make hardware. They used to make strength training machines, and now they're kind of flipping over into more this kind of virtual, I guess, tech-enabled service model a la Hinge. Makes sense, because Hinge has been killing it, right? I mean, they're doing amazing, and they're showing nice outcomes other than cost savings as well, from what I understand. So, it's virtual musculoskeletal care, right? Or you get a behavioral coach, or you might have a kind of like an app guiding you through physical therapy. And so you're saving cost for the employer, based on in-person visits, but you're also potentially decreasing the number of surgeries. People don't go to surgery. You're decreasing the number of prescriptions. And they have some nice figures about lower rates of usage of opioid prescriptions. So
one of the things that I'm seeing, I want to get your thoughts on, is that digital health is now getting much more kind of focused on one particular use case or one particular niche or specialty. So in this case, in these two examples, virtual physical therapy. And it is, you can customize the experience, and it ends up just being miles better than that like pack of paper that you'd get post-surgery. Hey, do these 5 exercises, then you have like a static picture of one part of the exercise.
Right.
And then I'll see you in several weeks, or come to this this location where we have physical therapy to meet with your therapist. But obviously that's difficult with scheduling and driving out there and everything. So,
yeah, that's right. And the question for me is whether how does this model work outside of musculoskeletal? Mm-hmm. And there's a bunch of startups and more established companies that are trying to do it with mixed success, I think, right? MSK is nice because it's very defined. It's there's good metrics, success metrics.
And it's mostly an acute, and it's back to the acute versus chronic.
Exactly,
it's
right.
Pretty much an acute intervention. You had a surgery, you're trying to prevent a surgery. You want to focus on it for the next 3 months, and then hopefully you feel better and you've built up your strength. And that's very different than if you're going to treat diabetes or cardiac care or something, which is much more long-term.
Yeah, that's right. That's right.
Okay, so the next story in Fierce Healthcare as well, Hims & Hers Q1 revenue doubles. They had this Super Bowl ad, and they were in questionable legal position compounding
that's right.
GLP-1s. And it has really worked out for them. They got a lot of new users into their, subscription service, and then they ended up navigating their way to a deal with Novo to now be legally selling Wegovy.
Yeah, exactly.
It's been a really, really smart, well executed. I'm not sure that they had all that foresight, but they were kind of, luck favors the bold. They came out with a really strong Super Bowl ad, and then they figured it out. So.
Right, and perfect timing too, right? Going from the, the announcement about the FDA kind of cutting, not clamping down, but saying that there's no more shortage, right? Which was the excuse for being able to compound semaglutide, and now they have this great announcement with Novo Nordisk. So I think they hit their Q1 numbers, but they lowered their guidance for Q2, or the other way around. Either way, they're doing really well, and they've plotted a good course.
Yeah. Okay, and on the other extreme, we have two bankruptcies. So Weight Watchers has filed bankruptcy. They have been struggling for a couple years, I think. And they really made the decision to no longer offer that in-person weigh-in consultative kind of session, which was a cost-saving move. Mm-hmm. But I think that was the final nail. The few people that still liked Weight Watchers, that was the core thing they liked. And so even though it saved money, it ruined the revenue.
They've been around for over 60 years. I did not realize that. I remember the adults talking about Weight Watchers when I was a little kid.
Oh, yeah,
it's just it's been like a fixture in our society for so long. But they're going bye-bye. And these legacy wellness brands.
Yeah, it's probably there's better products out there.
Yeah, exactly.
And then Rite Aid,
similar story.
They filed bankruptcy again, which I was really surprised about that quickly. I mean, inside of 2 years, it's hard for me to understand how you strike a deal with the creditors in bankruptcy one, and then that quickly it falls apart. But it did.
They're like the Sears of pharmacy. It's just like the slow. Well, it's not that slow, unfortunately, anymore. But they just weren't able to diversify their business, right? And they got killed with the opioid prescription litigation, and they didn't have a
PBM.
Yeah.
So I think a lot of the pharmacy economics were hollowed out by the PBMs.
That's right.
And PBMs were owned a lot of times by a company that also owned a pharmacy.
That's right.
But Rite Aid didn't have that advantage.
Vertically integrate or die.
Yes. Okay, moving into pharmaceuticals. So Lilly had their earnings. They had revenue up. They're doing well. They have sort of been a much better company and much better stock than Novo Nordisk, although Novo has made progress to sort of stem the bleeding recently. Lilly has really just been killing it, really doing well, and they did again. So, and it's a U.S., it happens to be in the U.S., and so all the Trump policies, I think, benefit Lilly. They already do a lot of work here.
For sure. Their earnings report reads like a GLP-1 love letter, right? I mean, it's and they're positioning for. I mean, they're obviously these drugs are not just for. I mean, you've talked about this before. They're not just for obesity anymore. They're diabetes and metabolic health, and I mean, it's going to be depression. They'll make your car run faster. I mean, it's going to be everything.
Right, right. And then Novo had their earnings, and I think they are they're doing better. It's been a hard year with Novo, but they seem to be sort of turning around.
Yeah.
And so,
and I think some of their headwinds was that competition from the very compounding pharmacies.
Yes, right. So that is stopped. The question now is, do they get the scripts and the fills, and do they see that growth again through these distribution channels?
Yeah. And of course, they're awaiting Trump tariff announcements as well.
Right. Okay. I didn't know this company. So in Axios Pro, Biotech Alchemab struck a deal with Lilly, licensing their technology to Lilly. They're in London, and they're developing sort of neurodegenerative disease treatments. What do you think about this company?
I didn't know about them either. They were really, really interesting to read about. So yeah, UK based, like you say, and their field is resilience biology. So what's resilience biology? It's this idea that you find individuals who either have a disease or they have a genetic predisposition to a disease, who at the same time are not showing manifestations of the disease, like their symptoms are mild, or maybe the disease has not progressed as fast as you expect. And the idea is that these individuals they have something special about them, right? Something
in
resilient.
Their genetics or in their body that's helping them.
Exactly. Yeah. And so if it's an immune system, there may be, if the immune system kind of a factor, maybe there's like an antibody that you can isolate and use that antibody as a commercial treatment.
Yeah.
And so that is the idea. Super, super interesting. I think it's interesting too with again, going back to the MAHA movement. This is not really that upstream in terms of prevention, but it is kind of looking upstream in terms of individuals who, for whatever reason, are not showing the disease or the biology as aggressively as others, and using that to make a treatment.
Yeah, and the licensing structure is interesting too, where they didn't sell altogether. They licensed it to Lilly, which I think more creative deals in pharma would be good. So, okay, in the About Health and Us, more of a health and wellness kind of section that Marcus and I touch on, we have a New York Times opinion piece. So this is not in their hard news. It's an opinion piece. The title's "In a World of Addictive Foods, We Need GLP-1s." And it's written by David Kessler, who is a former commissioner of FDA.
Pretty far back,
yeah,
I think.
Maybe during Bush. I'm not exactly sure. And he has a new book coming out, Diet, Drugs, and Dopamine, The Science of Achieving a Healthy Weight. So it's a long op-ed piece, but really talking about the concept of food being addictive and the GLP-1s being a way to kind of help you detox off of it, and then you titrate off the GLP-1 and you're eating healthy and living a healthy life.
Yeah.
So anyway, what are your thoughts about this?
Well, it's another great piece, I think, to hold up in this context of this discussion of MAHA, right?
Yeah,
because here he's taking these GLP-1s and he's saying on one hand, we have this miraculous drug. On the other hand, they're kind of the reason we need them is because we have this food supply with these ultra processed, highly addictive, sugar and fat enriched foods. And so it's like the GLP-1s, are they a real solution, or are they just like a high-tech Band-Aid? Right, is the question. And ultimately, do we want to be investing in prevention or profitable pharmacology?
Does it matter?
Maybe not. Maybe not. Or maybe it's both.
Yeah, I think it's both. I'm very much in favor of trying to bring healthy foods into a price point that if you are struggling to feed a family of 4, it is a really good option to have healthy fruits and vegetables and foods, which I don't know that it is today.
Agreed.
But I also think using GLP-1s to help people who maybe have eaten ultra-processed, maybe not that healthy foods for 20, 30, 40 years, it may not be enough just to start offering healthy foods, but to give them some transition tool.
Right.
So I think it could be both. But we'll see. Yeah, I can't tell if it's with the Make America Healthy Again kind of movement and now all of the regulatory apparatus starting to turn that direction. I'm noticing all of this health prevention activity because I'm paying attention to it more? Or are people like Dr. Kessler writing a book that he's been thinking about for a while, but he feels like now's the time that kind of the zeitgeist is ready to absorb it?
Yeah.
I don't know which it is, but there's definitely more. I'm noticing much more health and wellness sort of news stories and books and podcasts and everything.
Oh, absolutely. That's what everybody's talking about, right? And here I am, I'm wearing my Oura ring.
Yeah, right.
There you go. There was one, it reminds me, there was another kind of pushback or criticism of MAHA that I meant to mention earlier that I didn't. And it's this idea that, and it kind of dovetails with what you're talking about, this idea that like this MAHA kind of zeitgeist, this ethos, it kind of puts a lot of responsibility / blame on the individual. Like the individual should be finding, healthier food. The individual should be sleeping more and getting more exercise. And, the reality is there's the larger socioeconomic forces out there such that, maybe people don't have access to healthy food. Or maybe for whatever reasons, they can't sleep, a good 8 hours a night. And that's been a little bit of pushback too. And I think you need to bring that into context here too. Not that I'm saying that GLP-1s are the answer to that.
Yeah.
I think those are other answers to the socioeconomic problems.
But if we are subsidizing corn and corn syrup, which I think we do as a country,
right, maybe
we could subsidize something else or take half of those subsidies away and try to find something more healthy than corn syrup.
Yeah, that's right.
But yeah, getting the price point down and making it easy for people or even advantageous to raise a family that is struggling to get ahead. We need to make it so that it is the natural kind of low friction way to go to eat healthy.
That's right. And I think the GLP-1s are important, and we can't neglect that. But we need to take the wide lens view.
Yeah. Okay, getting into AI. So you know a lot about AI. So I'm excited to get your perspective on this. In Fierce Healthcare, Pager Health rolls out a new AI agent to guide health plan members through wellness. So again, wellness delivered through payers. I think they also work with employers. And so it's an AI agent helping members with wellness and care navigation.
Now, and I didn't read this one, does the agent help navigate between different platforms? I mean, I know it's a care navigation platform, but is it?
Yeah, so I think it is. You have your provider network in, we're in Tennessee, so maybe they're in Blue Cross of Tennessee. I don't know if Pager sells to Blue Cross, but the payer provides Pager Health's AI agent to their members, and they sort of help with that navigation. What docs are in my network? How do I do this? But also they help with sort of general wellness. Many questions you have, maybe you don't need a doctor to. You could ask someone else. And I think the reason they sell to payers is that reduce the cost of care, right? Like if you can answer it with a nurse or even a call center, maybe the AI agent can answer for you and help you understand there's an over-the-counter solution, or that you could maybe walk more, get some exercise, and you wouldn't have headaches as much or whatever. I'm not sure those are right examples, but that's the concept, I think.
Yeah. Well, this kind of, and again, we've talked about this before. There's two worlds out there. There's clinical AI that's actually kind of making, trying to impact on decision makings for clinical care, and then there's non-clinical AI, and non-clinical AI is far outpacing the clinical AI at this point. And so this, I think, is a good example of that non-clinical AI here, kind of helping with this care.
Yeah, this is in the coaching. Maybe they group together 100 people that are trying to lose weight into like a competition challenge, steps challenge, or things. But it's also, I think, going to affect the referral patterns, where, physicians and health systems then are impacted by it.
Mm-hmm. Yeah. You got to I just have to ask the question, like, if the core problem is the complexity of the healthcare system, how about making healthcare less complex rather than building an AI tool for it? But I know that's naive. So,
okay. And DaVita, the CEO of DaVita, Javier Rodriguez, is leaning into AI. And so DaVita has been doing dialysis for, end-stage kidney disease patients for a long time. It's not clear to me how he's leaning into AI, but but he is talking about AI a lot. So what do you think about DaVita?
Yeah. Well, so I guess first, when a dialysis giant starts sounding like a data science data science
maybe
firm,
we're getting towards peak AI.
Maybe the shift is real. So they say they're going to be using AI for risk stratification and care coordination. Here I got to say, again, this is not meant to be cynical, but there's AI out there, and then there's like Excel spreadsheets that are dressed up as AI. And I wonder what this is, right? I mean, I would love to take a peek inside, what does this model look like? What are its inputs? I remember a conversation I had a few years ago with a CTO of another chronic kidney care firm. And they also had a kind of a proprietary, they call it AI tool, for kind of risk stratification. And I asked them, what are your inputs? It must be a really complex model. And after a couple of beers, he finally said, don't tell anybody, but basically we can get 98% of where we want to be with a zip code and a creatinine level, and the rest is just, it doesn't really add anything. So I don't know. I wonder.
I mean, this patient population is pretty sick, and I mean, it's end stage. So they're on dialysis. They need to be risk stratified, but it's a very finite set of things you're risk profiling.
Right.
I think.
Exactly.
So
that's
just not as complex as different parts of healthcare.
That's right. But anything that can keep patients going and to push off the need for transplant.
Okay, so moving into more of the AI standard technology companies, OpenAI, so this is a Wall Street Journal, abandons the planned for-profit conversion, which I was shocked about when this came out this week because they have raised money around the idea of turning into a for-profit. I think some of those investors can claw their money back. So, Adam, what were your thoughts about this story?
That was kind of where I went with this too. I mean, so again, background, this is part of this big soap opera that's been playing out, right? With Sam Altman feuding with Elon Musk, and then, he was fired and then he's rehired, and Satya Nadella from Microsoft is involved. I mean, it's a whole big drama.
Well, as a VC, I think if one can start a business in the nonprofit setting, do a bunch of R&D on a tax deductible basis, and then when one works, so maybe I do my portfolio, all of that, I do 10 of them, and when one works, I flip it to for-profit. That doesn't seem like it works for our tax system.
Yeah, what was that nonprofit status for in the first place?
Right. Yeah. And so I think it's pretty complex to make this transition, and it seems like it's failed. They're not going to be able to do it.
Right. Now, I doubt this has a big effect on ChatGPT and what OpenAI is doing commercially. I mean, it's a commercial operation, right? I mean, it's making tons of money. But yeah, my thoughts went to investors, and for future fundraising, I think it makes it more difficult.
Yeah, and it's going to, I think, impair Sam Altman's ability to have full freedom of movement to do whatever he thinks is best for the business competitive landscape.
Yeah,
he's going to now be beholden to the nonprofit board, which has this nonprofit mission.
Fiduciary duty to humanity.
Yes.
Yeah.
Right, which is maybe vague, but very different than drive shareholder value.
Right.
Related to that, I guess, is they are going to buy the startup Windsurf. So the first really big commercial use of AI that has taken off has been as a coding assistant, co-pilot, or sort of, pair coder that is not a human. Yeah. Cursor, which we'll talk about in a minute, was sort of the first in that space. And then Windsurf is the one that sort of came out with the Pepsi version of Cursor's Coke at half the price. I've used both of them. And it is as good at half the price. And so I switched over to Windsurf. I think it's really smart for OpenAI to buy it. because it will get a whole bunch of users and sort of solidify, what is the number 2 player in the most attractive early space. What are your thoughts about this?
Yeah, and it shows that, yes, they're remaining not for profit, but that doesn't mean they're not building aggressively, right? This is a big deal, and this is why I'm not really encouraging my kids to do a lot of coding.
Yeah, that's right. And I don't know that there's not going to be a third and a fourth and a fifth that just keep having the price.
Yes, right.
But I think for OpenAI and for Windsurf, it's a good outcome, right? They sort of solidify their market position. The Windsurf investors get out. Mm-hmm. I was at a dinner with a bunch of VCs and the product lead for Anthropic maybe 2 weeks ago. And that was the discussion. There's some business models that you can have a huge advantage, but there's really no moat. Mm-hmm. Right? So you can grow really quickly, but you have to exit quickly.
Right.
Because it's just going to be, it's commoditizing everything. And then the discussion at dinner was what areas is it possible to build a moat? And really data and trying to lock in users in some way, but locking in users is hard. So it ends up, you need some kind of proprietary data source.
Yeah. And the data is becoming more plentiful, at least certainly in healthcare. So even that's not a great moat.
Yeah.
Anymore.
Well, yeah.
Depends
it has
on
to be
where you are.
Proprietary data that no one else can get, which is, hard to find.
Yeah, exactly. Yeah. And data that can't be replicated from another source.
Right. Okay, so then PitchBook had a really interesting report on Cursor, which is the one I just referred to as the first entry into the software coding space. They have increased their valuation 20 times since August. And so the number of months, so Cursor launched 27 months ago. They didn't exist 27 months ago. And let's see,
this is the
3 months ago.
Vibe coding.
This is the vibe coding. Coding.
I love that term.
Yeah. And so they're it's just an exponential curve. They are valued at little over $9 billion right now and just growing incredibly fast.
Yeah. I want to see a graph like that.
On one of my portfolio companies.
Exactly.
Yeah. But I think also the market is growing very fast.
Yeah.
And they're the leader. But at the same time, Windsurf started after them and now just sold for $3 billion. And I used to use Windsurf and now I'm not using it anymore because I found another tool that is better, I think, and less expensive. And so the issue is sort of this commoditization is happening. I think Cursor is trying to go it alone, but they have to run pretty fast to keep
it's
up.
A great example of what you're talking about. I want to find the next Windsurf and invest there. I mean, but do it really quickly before they're leapfrogged by somebody else.
Exactly. Okay, so I want to talk about AI agents. You've been in the space for a long time. I've been looking at AI agents really out of the crypto space probably for 6 months, but they have broken into the mainstream, first with Google talking about it. Now everyone seems to be talking about it. But the Wall Street Journal had a pretty good article for our audience that maybe is in healthcare and hasn't really focused that much on the difference between an AI chatbot and an AI agent. And so the title in the journal is AI agents are learning how to collaborate and companies need to work with them. And it's really talking about how AI agents can interact with other AI agents in this kind of network of automated, semi-autonomous, pretty intelligent entities. And they're empowered to do a finite set of things, but they can do that autonomously. And together they can be pretty impactful. What are your thoughts about where we are with agents? Is it all hype? Is it going to be impactful? Should we be paying attention to this? What are your thoughts about that?
Yeah. Well, agentic AI is really hot right now. As you know, you and Marcus have been talking about it a lot. It's been really talked about a lot ever since Jensen Huang's keynote a few weeks ago at the GTC conference. So I think that this article lays it out, and you've laid it out well before. I mean, I kind of think of agentic AI really simplistically as, if the current generation of tools will kind of answer your question and give you ideas, the agentic AI will actually do it, actually carry out those ideas. And that becomes really, really powerful if you start thinking about it. Especially if you start thinking about kind of agentic AI talking with each other and kind of these complex networks. The other thing, another example would be like an agentic AI. I could say to the agentic AI, use Google Maps to help me find the closest route to the airport or something. And the agentic AI would open up Google Maps and, which doesn't seem like a big deal. It's not hard for me to open Google Maps myself, but it takes me a couple seconds to do it. But then you think about like some really, really complex workflow with like thousands and thousands of instructions, agentic AIs could do it within a few seconds. It would take me hours to do. And so that's when it starts and then you start thinking about, things it can do for healthcare and finance and all these different industries. It can be kind of mind blowing. But I think you guys were talking about this last week. I also I think we need some pretty sharply defined guardrails on these things. The idea of kind of autonomously operating networked AIs with agency, starts getting a little
where are the boundaries? And I think right now it's not clear. And speaking of that, I feel like Zuckerberg every week with Meta is out like pushing the boundaries further and further. But in their journal this week, Zuckerberg's grand vision, most of your friends will be AI.
I think most of my friends are already AI. I don't know why this is such news.
Most of your friends are AI right now?
No, I'm just kidding. But
I think that's a dystopian world that I don't want. I mean, he's saying it as a positive thing. So the basic concept is that most people would like to have 10 to 20 close friends. And most people, and he knows because he sees it on his network, most people actually have 3 to 4 friends.
Yeah.
And so his jump that I don't agree with is therefore we should fill in with AI friends to fill the gap that's needed. I'm not sure that is a good substitute.
Yeah. Well, I don't know. Is it therefore we should, or this is going to happen because that's inevitably that's where we're going to go. I mean, we have so many things pointing us in that direction. I mean, loneliness is a real problem. Social isolation is a real problem. It has only increased since COVID and is propelled by, all of technology. We can do anything we want remotely, and we don't have to interact with people anymore. And at the same time, you've got these LLMs that are getting better and better. We know from research that they are more empathic, right? Like comparing LLMs to physicians, right? The LLM is going to deliver more empathy and have a better interaction than your physician. And so, they're going to be our friends. They're going to be our therapists. They're going to be our lovers, right? I mean, we won't get into that whole discussion about Meta and the sex talk, but from last week.
Yeah, but so you think this is inevitable? It just is.
I don't know if inevitable is the word, but I think that our momentum is carrying us in this direction, is what I would say. You don't think so?
Yeah, maybe. I think it's sad though, so I'm resisting.
Oh yeah, I'm not saying it's not sad, but so
it probably is. I think it is. There's a lot of momentum in this direction, and it is self-reinforcing, right? So as people get more connected with AI, they will see no reason to go work on a messy human relationship.
That's right.
So then they'll be more lonely and more inclined to do AI, and then it just sort of perpetuates everything.
That's right. Yeah.
So I'm fearful about that, but
no, that's
probably right.
It's definitely a dystopian vision. But I think what Zuckerberg, I don't want to put words in Zuck's mouth, but I think he's talking about a world where we are cohabitating with AI. Not necessarily AI replacing our social connections, but maybe augmenting them in some way. But it's easy to kind of take that and go to some dark places.
Yeah. As agents start doing things in the world, they're going to need to pay one another and pay for services, buy data from someone, or maybe transact or something, pay an influencer on social media, or buy a keyword in a search. And I've been trying to think about how that would happen. Visa is bringing out a tool that would allow me to sort of provide a budget and let an agent use my Visa card.
Mm-hmm.
So that might be possible. But Tether came out this week. We're showing an X post by the CEO of Tether. So Tether, they do a bunch of things, but they're best known for their stable coin, USDT, which basically mirrors the value of a dollar. USDT is held at $1 per one USDT. So you can move in and out of Tether, and every Tether coin is worth $1 always. And then they are backing that with mostly U.S. Treasury bonds, but other things too. And it's a pretty interesting business model. I wish that you and I had thought of this.
Oh, man.
I tried to invest in a
Absolutely.
stable coin, but I was just like a touch late. But
Same here. I wonder if it was the same coin. But anyway.
Yeah, probably.
Probably.
So anyway, their business model is for the audience is they hold the U.S. bonds. It makes 5% a year, say. They don't pay interest on the dollars that you use to buy USDT. So it doesn't pay interest on your stable coin. And then they are making that interest rate, and they're just printing billions of dollars. It's a very successful model.
Yeah.
So they have come out with Tether AI, which is an open source way to, in a sort of trustless, fully automated way, allow AIs to interact and pay one another. And I'm following this because I think a lot of the AI transactions are going to be at the 1 cent, even below a cent.
Yeah.
And AIs will need some way to do that in a format that is not based on, I know Rick Abramson and I trust that you didn't steal this money and it actually is going to be sent to me. And Tether is the only stablecoin that I know of that has scale, that you don't have to go through the KYC process, which in the US, like I'm on Coinbase and other things, and it's fine. I can give my driver's license and I pay my taxes. I'm not trying to dodge that. But if I have 15 AI agents doing various things, I don't know how to KYC all those agents. I don't even know what that means. And so anyway, I'm following this. I wanted to see your thoughts on it.
It's super interesting. And I when you first showed me, I had to double check to see that it was the same Tether, right?
Yeah, right.
But it is the Tether, USDT Tether, which it's an amazing success story. They've had some compliance challenges, but like they are a dominant player. And yeah, it does make sense for all the reasons you said, especially for these kind of like fraction of a cent transactions that it might take place on
like this guy says massive inflation for agent infra builders. I mean,
exactly. Now, the only thing I don't know if necessarily if it has to, I mean, linking agentic AI with a blockchain, that makes sense. And linking it with a cryptocurrency makes sense to me for those reasons. I don't know that it has to be a stable coin at the end of the day. I mean,
I don't think it has to be a stable coin.
It just has to be something with fast transaction, like settlement speeds. I don't think you could do it on Bitcoin, maybe on the Lightning Network, on top of Bitcoin. I don't know. But
it has to be in a currency that most people understand what it means.
Yeah.
So you could have, it could be the euro, it could be yen, could be Bitcoin, maybe. But there's not that many that you could go to that would be, I don't know. That's an interesting question.
Well, because you could have the transactions occurring, in pretty much any crypto token and then just convert it to your home, native currency on the back end.
Yeah, but you'd have to have some kind of oracle keeping up with the conversion rate.
If you're doing it in real time.
Yeah.
Yeah.
Right.
Yeah, for sure.
Right.
It's really complicated, but that's gonna be fun to watch play out.
The Guardian had a story about Amazon making a fundamental leap in robotics. They're bringing this invention to Europe, the UK and Europe first. But the leap is that the arms or the appendages that the robot uses to grab things can now feel the item and use touch to distinguish between things. And it's going to allow Amazon to bring many more robots into the picking and packing process in their warehouses. And so I think robotics is quickly sort of interacting with AI and kind of iterating back and forth, where AI is making robots better, robots are making AI kind of more useful. What are your thoughts about this story?
Well, it's kind of like you ask yourself, like, why aren't robots everywhere, right? I mean, we've got this amazing technology. Mm-hmm. I mean, we've got software that just blows your mind. Why aren't we using robots for like every single chore, every single activity in our daily lives? And I really think that one of the big rate limiting steps is this sense of touch, right? This tactile feedback. If I tell a robot to pick up like a wine glass, it's probably going to crush the wine glass, right? Because like that's really, really delicate feedback that you need in order to grab something with enough friction to hold it, but not so much that you're crushing it. And if this is what Amazon has come up with, I mean, there's research teams working on this all over the world, right? But I mean, that will be like a tipping point, I think, this kind of tactile feedback, right? I thought that the story itself was a little misleading because I got all excited about robot touch, but it was more about the robots being able to know which boxes in the warehouse they can pick up and which they can't. But apparently it's a major step in that direction.
Yeah, right.
And that'll be huge.
Yeah. Okay. And then the last story here in the U.S., Aurora is a automated driving company. They have focused on trucks, like 18-wheelers. They now are fully autonomously driving these 18-wheeler trucks with loads of cargo between Dallas and Houston, making deliveries. And there's a video that we'll link to where you can watch. There's no driver in it, and it's on the highway, and other cars are around, and it's driving from Dallas to Houston.
That's awesome.
What are your thoughts about this?
My wife loves this.
Really?
Well, yeah, because she hates trucks. Well, okay, she doesn't hate trucks. She doesn't hate truck drivers, but she hates trucks driven by truck drivers. She just thinks it's really unsafe, and so she's really she
thinks the autonomous truck will be much safer.
She thinks it'll be much safer, and she'll be much happier on the roads with an AI driven truck.
Yeah.
So and I know you didn't put that. I mean, I know that you put this in here because you probably want to talk about supply chains and lab testing and home delivery and all.
No, I think it's all interrelated. Like
it is.
Humans trusting that the autonomous driver is better than a human driver is a huge adoption question.
Yeah. Oh, exactly, for sure.
And so that's interesting that I think that makes sense that truck drivers drive for long periods of time and it's a hard job.
It's hard. They get tired.
Right.
It's tough out there.
Yeah.
Yeah. But I think to your point, the adoption question, I mean, there will be a safety incident, right? Something will happen. And that's the real question. After that something happens, are we going to see a huge delay, huge setback in this technology? Or are people going to realize that, like, hey, the rate of these accidents is like a mere fraction of the rate it is, with normal human drivers? Because that's what it is for cars, right? For self-driving cars. Yeah. I mean, 45,000 automobile deaths a year, I think. And we could,
and a lot of human error.
A lot of human error, yeah. But unfortunately, like one incident with an AI-driven car kind of sets the industry back several years. And people are becoming more comfortable with it. I think there's some Waymo cars that are here
Oh, here in Nashville?
Somebody told me that last night. Yeah.
I've been wanting to ride in one, so I definitely want to check that out.
Me too.
Yeah, so I'm following this because I think Waymo seems like they have really they're figured out where they're starting to grow their base. I'm excited if they're in Nashville. And then this truck company I'd been watching, they were sort of delayed, but now it seems like they're up and going. And the interstates seems like an easier problem to solve than neighborhood traffic.
Yeah.
So
yeah, I think so. I think so. I wonder if they have robots loading the trucks.
Yeah, I know that's the thing. They probably can add that over time.
Yeah.
So. Okay, well, Rick, thanks for doing this. Really enjoyed talking through things. Lots of stories as usual. I appreciate you filling in.
This is so much fun. I am so honored. Thank you for the invite. This is a lot of fun. I don't think I'm leaving here knowing master level jiu-jitsu, but every time I spend time with you, I come out smarter. So thank you.
Good. Well, it's been great to have you. And then people should check out, I'll put in the show notes, episode 73. It's a little bit dated, but we talked through AI last summer, which was great. We'll add that as well.
Very cool.
Thanks, everyone. See you next week.
See ya.